These 4 projections reveal severe structural changes. The skin is retracted, the nipple complex is pulled inward, and the entire breast shows gross deformation. When processed by advanced artificial intelligence algorithms, the AI heat maps shown here, the technology either misses the abnormality entirely or underestimates its true boundaries. Detecting non-calcified architectural distortion remains one of the most difficult perception problems in breast imaging for both human radiologists and AI. These images belong to a 69-year-old woman who years before this stage noticed a palpable thickening in her breast following a severe automobile accident. For over half a decade, she persuaded her physicians that the mass was a harmless scar from that collision. Her insistence created a powerful cognitive anchor for the clinical team. Accepting a plausible benign explanation, such as traumatic fat necrosis, prevents an observer from identifying the destructive biological process unfolding within the tissue. A case report by Dr. Laszlo Tabar, Peter Dean, and Miklos Taryan deconstructs the mechanics of this clinical trap. Their research indicates that the traditional diagnosis of invasive lobular carcinoma is biologically inaccurate and contributes to frequent misdiagnoses. The authors propose a reclassification: breast cancer of mesenchymal pluripotent hybrid stem cell origin, or BCMO. BCMO does not form a distinct measurable mass and lacks the characteristic skipping stone calcifications that typically signal malignancy. Without calcifications or a defined solid border, automated detection systems have no specific target to identify. Diagnosis relies entirely on the radiologist's recognition of subtle, evolving tissue patterns. Intercepting this disease requires looking past the search for an epithelial mass to understand how tumors grow at the mesenchymal level. In the 69-year-old patient, this progression began 72 months before her diagnosis. On the right MLO projection, a faint region of non-calcified architectural distortion is already visible. At this early stage, the lesion does not disrupt the concave border where the fibroglandular tissue meets the adipose layer. Over time, the right CC projection reveals the internal structural changes. The central fibroglandular tissue is shrinking and pulling inward. At every follow-up examination during this phase, the patient reinforced the narrative that the thickening was simply an old injury from her car accident. The internal pulling eventually grows severe enough that correctly positioning the breast for a standard mammogram becomes difficult. A benign radial scar also causes tissue distortion, but typically presents with a low-opacity radiating structure known as a black star. Invasive duct-forming carcinoma, or neoductgenesis, eventually develops skipping stone-like calcifications. Without fluid-producing micropapillary signs, or calcified clusters, the limits of visual diagnosis are tested. Because the structural shrinkage happens at an imperceptibly slow pace, it mimics the static nature of healed scar tissue. This macroscopic timeline camouflages the malignancy. Exposing the biological reality requires analyzing the cellular mechanics. We move from the macroscopic view of the mammogram, past the ductal networks and lobules, into the cellular matrix of the extralobular mesenchyme. The name invasive lobular carcinoma implies that this disease originates within the acinar epithelium of the lobule. Cell culture studies show the malignancy actually arises from the pluripotent hybrid stem cells located in the extralobular mesenchyme. Once transformed, these stem cells begin to biologically mimic epithelial cells. The rogue cells spread through the interstitium in successive interlacing thin sheets, which prevents the formation of a cohesive mass. As these sheets migrate, they stimulate local fibroblasts into overdrive, prompting them to produce thick layers of collagen that entangle the cancer cells. This continuous production of dense fibrous tissue physically pulls and tethers the surrounding tissue matrix. That microscopic tethering causes the large-scale architectural distortion and tissue shrinkage observed on the mammograms. Large-format histopathology shows these pink tracts of fibrous tissue dominating the biological landscape. A clinician palpating the breast is feeling the patient's own collagen network, which has been hijacked and thickened by the underlying malignancy. This mechanism explains why standard biopsy protocols often return false negatives, which reinforces the illusion of a benign scar. Fine needle aspiration depends on drawing concentrated clumps of cells out of a defined mass. In BCMO cases, the thin biopsy needle simply cannot extract the sparse malignant cells locked within the impenetrable collagen web. Ultrasound is required to penetrate this tissue density. These scans reveal the lesion and its acoustic shadowing, exposing the structural disruption obscured by the mammogram. Accurate diagnosis requires the force of a 14-gauge core biopsy or direct surgical excision to punch through the fibrosis. A large bore sample captures enough tissue architecture to differentiate between granulomatous mastitis, a radial scar, and true BCMO. Relying on fine needle aspiration when presented with non-calcified architectural distortion leads to underdiagnosis. Radiography of the mastectomy specimen provides physical proof of the pathology. The radiating spicules of fibrosis have consumed the surrounding healthy tissue across a massive area of architectural distortion. The definitive histopathology report confirmed a 24 by 13 mm BCMO combined with solid-form malignant foci. Immunohistochemical biomarkers confirm the origin of these rogue cells. The tissue shows positive staining for ER and GATA3. The persistent thickening, consistently defended as post-traumatic scarring, proved to be a highly structured malignant network. The consequences of cognitive anchoring are documented in Case 2, where an 82-year-old patient attributed her mass to a fall. She refused surgery and eventually died from disseminating BCMO. A palpable thickening associated with non-calcified architectural distortion must always be treated as a malignant process. Clinicians must disregard patient histories of physical trauma when these specific imaging biomarkers are present. Effective protocol requires bypassing fine needle aspiration, utilizing multimodality imaging, and mandating a larger bore tissue biopsy. By identifying the malignancy at the mesenchymal level, clinicians can move past the search for an epithelial mass and identify the lethal fibrosis hiding in plain sight.